Good evening, everybody. The COVID times actually has closed some doors but opened many windows. One such is this live webinars where we can reach out to maximum number of colleagues and can learn and listen from the experts. We in Kujbihar Duar's Academy of Pediatrics was planning since long that we also can host such webinars. Things have become possible so that we have started a series of Saturday webinars. To start with, we are having some classroom webinars where we are going to learn the basics of some subject like CT scan, EEG, ECG, and basic cardiology. To start with, today we are having the classroom webinar series 1 with CT scan named What Tell Does the CT Scan Tell? That means we are going to learn the basics of CT scan, the abnormality in a CT scan so that we can pick up the abnormalities by ourselves, not depending on the reports of the radiologist, which often comes a day later. We have a very dynamic speaker tonight. I'm going to introduce him shortly. Now, I'd request our president of Kujbihar Duars Academy of Pediatrics, Dr. Vinayak Roy, to say a few words. Dr. Vinayak Roy.
Thank you, Dr. Banerjee. I, Dr. Vinayak Roy, on behalf of Kujbihar Duars Academy of Pediatrics, welcome all the participants to this basic yet unique webinar. As Dr. Banerjee said, reading a CT scan played by ourselves poses a quite problem for us, and we have to depend on the reports which often comes a few hours later. Our speaker tonight will make things easy for us to interpret the plate by ourselves. I take the opportunity to thank West Bengal Academy of Pediatrics President, Dr. Subroto Chakraborty, for his encouragement to start this first ever webinar of our branch. And with all your participation and enthusiasm, we will have much more to offer in subsequent Saturday series. Meanwhile, I also convey my sincere thanks and gratitude on behalf of our organization to the digital partner Sun Pharma for their kind support. With this, I conclude and hand over the platform to Dr. Banerjee again. Thank you.
Thank you, President Dr. Vinayak Roy. Now, I would like to invite the president of WBAP, Dr. Subroto Chakraborty, whose continuous encouragement has actually made this possible. He always says that the flow should be from the center to the districts and not from the districts to Kolkata. So that is the motto we have picked up from him, and we have started this webinar. I invite our president, Dr. Subroto Chakraborty, to say a few words. Dr. Subroto Chakraborty.
Video on.
Thank you, Dr. Biplab Banerjee. Biplab Banerjee has been one of our students and also a junior colleague at Institute of Child Health. And I say my regards to President Kujbihar and Duars branch, Dr. Vinayak Roy. And also I can see the dynamic radiologist, Dr. Samir Mondal. So I think it's a wonderful concept. It's a wonderful concept you are starting. My best wishes and congratulations to Duars, Kujbihar and Duars branch. And the concept, regarding the concept, people have rightly said that it's a unique. Just I was going through it. It is very unique in the sense that you are touching the basics. Say in medicine, that is I always say that basics is the most important thing. Basics and clinics is the most important thing. Rest all is secondary. I say very interesting. I always say that clinics is the everything, that is everything, and all other things are your supporting evidence or circumstantial evidence. So they are also helpful, but building the clinics means building yourself, and you take help of all the things like radiology, like laboratory, in building yourself. So, you have taken the right step, that you have started from the basics. It's very interesting that name is also very interesting. The classrooms, your classroom series. That means
Classroom web.
you, classroom series. That means you are starting the basics again. It's a wonder. It's a, again. I will say, and again, I was reading through which what Dr. Samrat Mondor is going to say is how the CT tells what CT tells. That is also again interesting. That is also pointing to the basics. So it's a. I would say that please continue that. Please start from just today and please continue that. And I think you have a long way to go, and I feel this is the best way to learn. It is not the way that we have been experiencing for the last 30 years, going to Calcutta, sitting in a hall, and then see some one way traffic. You listen from someone and come back and forget. But now it's even in this opportunity, this digital platform has given us an opportunity where we can interact. The knowledge only progress through discussions, not only it can progress through discussions. That is the most important thing. So I would appeal that after each session you have a long session of discussion. That is must. See speakers or whoever is present in the case, and then have a discussion. Then only it can progress. And people will rightly said that things have changed of late. I was in a meeting, a clinical meeting of the Murshidabad Academy of Pediatrics only yesterday, and they did a wonderful job. Now just see one thing, very interesting thing. 5 years back, did you hear of Murshidabad Academy of Pediatrics, or did you hear of Coach Bihar of or Duars Academy of Pediatrics? Now people know, everybody in West Bengal, every corner, every pediatrician knows about the Murshidabad Academy of Pediatrics, because they are doing very good, very good programs. And similarly, you have started, so please continue it, and you also have to reach there. And about the traffic, it is a wrong way. It is a mental blockade to say that the things don't happen in districts and we cannot do in things in districts. We can do. You have the colleagues. You can manage. You can do everything possible. Nowadays, say you can have the laboratories, the highest of the laboratories. They can collect samples from there, and let's say, and then they help you out. So you can plan every possibility is there. Only is to build up the companionship, build up the team, and the sky is the limit. So rightly again I would say that if the traffic should be reversed, it should not be from Calcutta to Duars. It should be from Duars to sorry, it should be from it's from not Duars to Calcutta, but Calcutta to Duars. So there could be one day that if you see patients will go to Duars, to a better hospital, it's a clean hospital, or in a natural surrounding. So it is quite possible. It is quite possible. Durgapur is also doing very good. So my only in my period, I always it has been my aim to so that every pediatrician in each and every corner of the city or any corner of the state gets motivated, gets the feeling that they are important, gets the feeling that they can do things. If we can do these things, we have done a lot. Again, I congratulate you, all of you, for starting such a wonderful session, and special thanks to Dr. Biplab Banerjee for inviting me to say a few words. Thanks you, and thank you, Biplab. Thank you, Dr. Vinayak Roy.
Thank you, sir.
Thank you, President Dr. Subrata Chakraborty. Subrata has been like an elder mentor to us, and surely with your encouragement and support, we should walk a long way. Now, on to the main program. We have the webinar series 1 on CT scan today. What tale does the CT scan tell? And the next few hours, Dr. Shamrat Mondol, who is a very dynamic radiologist, is working in PK Shah Hospital in Kuch Bihar, will take us through. Dr. Shamrat Mondol passed out his MBBS from Medical College, Kolkata, and did his MD in radio diagnosis from Delhi, Guru Tegh Bahadur Hospital. Worked in various hospitals in Delhi as well as in Kolkata. He has about 5 or more papers in international journals, and he's presently working with great repute in the Kuch Bihar PK Shah Hospitals and Research Center. Now over to Dr. Shamrat Mondol for your presentation.
Thank you, sir. Am I audible now?
Very much audible.
Okay.
Very much audible.
Thank you, sir. So at the outset, I would like to express my gratitude that I have been a part of something which is this much promising, and I hope to deliver up to the task. Well, the goal of this talk would be kind of increasing the communication between the radiology and radiologists and the pediatricians. So this is not like a core radiology webinar. This would be something where we would like to tell what sort of images, what sort of reports we give, what we want to express through these reports and these images. And also in some of the slides, I would like to share what the radiologists wish to know from the pediatricians during the requisitions. So the basic goal would be to increase communication. So 1.5 hours is kind of less time to cover the role of CT scan in pediatric radiology. So I would be going through some topics which have higher incidence. Some basic head anatomy at the outset. So when we see brain images in films, there are usually 2 types of images in the film. One is brain window image and another is bone window image. So first we have to recognize what is brain window image and what is bone window image, because all the fractures would be seen in the bone window image. So, if you can see the pointer, this is the bone window image, because we'll identify this image because the brain looks like a little more black, which is hypodense in terms of CT scan, and we can see that outer cortex and inner cortex of bone quite well. So this image, this sequence, which is called bone window, will be evaluating the bones only, and here the brain will look uniformly black. On the contrary, the brain window images, here the bone will look uniformly white, and we would be able to differentiate the gray and white matter. So for diseases of the brain, we need to look at the brain window images. Some basic anatomy. So when we film a CT scan head, we usually provide 35 or 70 images, and the radiologist gets to see in his computer about 250 images. But there are few particular images that if one sees in short time, 1 or 2 minutes, one would be able to detect the basic pathology. So only those anatomy I am going to share. So this is a sagittal image, and this is the cut. The pink line here represents the cut through which this axial image is taken, and this is called a supraventricular level. So this axial image is located superiorly along this pink line, and at this level mainly we see the gray matter and the white matter. The gray matter is in brain is peripherally located. This is the gray. This is location of gray matter, and the white matter is relatively more blacker, and it is more centrally located. So the blue line would be the expected location of gray matter, the cortex, and the white and the orange line would be the expected location of white matter. So this is one level of image that we should see. The next level is called the basal ganglia level or the ventricular level. So this axial cut is through this pink line. So at this level, the axial cut is seen. And here we should be able to see the basal ganglia, the basal ganglia is approximately like in this location and in this location. So the red circles roughly represents the basal ganglia. The orange lines are the internal capsule, and the blue circle is the approximate location of thalamus. So at this level, there are some important structures that we need to see, and these are the lateral ventricles. Then we look at a lower level. These are the level of the posterior fossa. And here we see this is the brainstem, and this is the cerebellum, and these are the temporal lobes on two sides. So the orange is the brainstem, green is the cerebellum. And after seeing these three levels, we should at least check at least one sagittal image, that is the sagittal image through the midline. And here we can see this is the level of pituitary. This is where the pituitary gland is located. This is the brainstem, and this is the cerebellum. So these important structures we should see: pink pituitary, green brainstem, and orange is the cerebellum. Now with this anatomy, I start discussing what we report in a head trauma case. So the questions that we try to show, we try to answer through our images as well as the reports are: what is the type of injury that has happened? Number one, how severe those injuries are radiologically. Number three is that sometimes, often brain trauma patients would undergo neurosurgeries. So it is quite useful to know how common neurosurgeries look in CT. And it is also useful to be able to detect an old injury and differentiate it from a new injury. And I would show some examples. So trauma brain, when we report three things. Number one, fracture. Number two is whether there is any intracranial hemorrhage. So this is the skull bone, and anything which is inside the skull bone, any hemorrhage would be intracranial hemorrhage. And there are certain subtypes that I would show subsequently. But intracranial hemorrhage is the most significant factor that determines the prognosis. And we also say whether there is any extracranial injury. This sort of injury is externally visible. Often the patient relatives are very conscious about these injuries. We write that extracranial injury means what is happening outside. This is the skull bone. What is happening outside the skull bone, in the scalp. And intracranial injury is what is happening inside the skull bones. So to see fracture with modern CT scans, first we should look at the 3D images, because very quickly in 30 seconds we get to see some fracture. So this is a fracture. So there are some other 3D images where we can easily see the fracture. Usually when we think if there is a fracture or not, we usually try to detect if there's a fracture in the skull vault. So this is the skull vault, that is the roof of the skull bones, and these are the skull base. So in a fracture in the skull base means there could be chances of CSF leak, and there could be other complications. So fractures, we report whether there's a fracture in the skull vault or a fracture in the skull base. Now, so while seeing the film, seeing the 3D scan would be the first step to detect fracture. But then we need to look at the bone window. As I said, a bone window would be recognized by that the brain would look black, and we would be able to see the outer cortex and the inner cortex both. And we see that there's a fracture in the right side of the frontal bone, and this needs to be corroborated with the bone windows. And here the fracture is looking like this. This is important because there might be vascular impressions on the skull bone, and those vascular impressions on 3D might look like just fractures. So this looks like a fracture, but then when we see the bone window, we see there is a vessel passing through. So to detect fractures, let's see the 3D image first, and then we need to corroborate it through the bone window. Next, we move on to the intracranial hemorrhage. Intracranial hemorrhage is something that is located internally to the skull bones, and they have been divided into 5 types: extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage. These 3 hemorrhages happen intracranially, that is within the skull bones, but outside the brain parenchyma. So they are often termed as extraaxial hemorrhage. So knowing the term extraaxial hemorrhage is important, because sometimes when the hemorrhage is very thin like this, it might be sometimes very difficult to differentiate whether it is an extradural hemorrhage or a subdural hemorrhage. And the radiologist might write thin extraaxial hemorrhage noted in left frontal region. Suppose if I see only this hemorrhage, so that means the hemorrhage is so thin, we have not been able to differentiate into subtypes. And then there is cerebral contusions. That means the hemorrhage that is happening in the brain parenchyma. And lastly, intraventricular hemorrhage, which happens in children quite often. So extradural hemorrhage and subdural hemorrhage, they are both intracranial hemorrhages, but extraaxial because they happen outside the brain. This is extradural hemorrhage. This can be easily identified by its shape. This is biconvex. And this is subdural hemorrhage, which can be identified by this shape, which is convex or concave. But there are also some shortcuts. Like an extradural hemorrhage is always associated, or not always, nearly always associated with a fracture. And subdural hemorrhages are quite long in length, and they often cross the suture lines. So extradural hemorrhages are intracranial hemorrhages, extraaxial hemorrhages, biconvex, and associated with fractures. And subdural hemorrhages are intracranial hemorrhages, extraaxial hemorrhages, concave or convex, and are often long in length, so they cross the suture lines. And this would be an example of a subarachnoid hemorrhage. So the brain has some outer projections which are called gyrus, and the corresponding deep part is called sulcus. So gyrus is the outer projection, and inner crevice, this is called sulcus. And if the hemorrhage is located in this sulcus, then we say that it's subarachnoid hemorrhage. And this is shown in this picture, where this is the blood, and this has gone into the sulcus. And the imaging appearance is just like this, irregular in appearance, the white hyperdense subarachnoid hemorrhage. And this would be an example of contusional hemorrhage. This means injury to the brain, and this sort of injuries are very commonly seen in the basal part of the frontal lobes and the anterior temporal lobes. This is the basal part of frontal lobe, and in the anterior, this part and this part, temporal lobes. And this would be intraventricular hemorrhage. So blood is located within the ventricles. So this is lateral horn. This is lateral ventricle, frontal horn of lateral ventricles, blood in the hair, as well as blood in the third ventricle. So I have gone through basic intracranial hemorrhages. Next, after showing these in our films, and we would like to describe in our reports how severe those injuries are. Clinically, pediatricians would be able to quite understand, but we would still like to give a quantitative measure for the severity. Now, the modern CT scans are, if the hemorrhage is within the brain parenchyma like this, the modern CT scans are able to give an accurate measurement, like 5 cc. This is a measurement given by the CT, and it is 5 cc. But if the hemorrhage is in the extraaxial location, that is intracranial, internal to the brain, but in an extraaxial location, then often the volume of the hemorrhage is not so important, as much important as is the thickness. So if it is an EDH or an SDH, we often give the maximum thickness. By thickness, we mean this, and more is the more thick the hemorrhage is, that will cause a pressure effect on the brain parenchyma. So this pressure effect can again be measured by what we call midline shift. Midline shift means an imaginary line connecting the midlines and how much it is pushed to one side. So this is a subdural hemorrhage, and this has been pushing the brain over to, and so the midline has shifted towards the left. This is the left side, this is the right side. This is the right subdural hemorrhage, and the midline has been shifted towards the left side. And usually, if the midline shift is more than 5 millimeter, then the patient starts having significant clinical symptoms. So while measuring severity of a brain injury, we often say what is the volume of the hemorrhage, what is the thickness of the extraaxial hemorrhage, what is the midline shift. Other important parameter is it causing any interventricular dilatation? So for example, this is our case from our hospital. There was an interventricular hemorrhage on 11th December. 1 day later, the ventricles have started dilating. We place these images side by side and clearly see this is the ventricle size at the almost at the same level. After 1 day, the ventricle have started dilating, and after 3 days, the patient was managed conservatively, and after 3 days, the ventricles have again started regaining their normal size. So, how severe is an injury? While describing that, we should be also seeing whether there is any interventricular dilatation. So this is just a summary, so we're measuring severity, and we move ahead. Now, so after you see the CT scan and you have assessed the severity in the CT scan, there are two things that one needs to quite remember. One is, look at this extradural hemorrhage. So this is 14 millimeter in thickness, we have measured. But there is the hemorrhage, which should be white. In the middle, there is some black areas. This is called swirl sign. Look at another extradural hemorrhage. This is totally white. So clotted blood looks like this, freshly clotted blood. But here we see some black areas within the hemorrhage. That radiologically we say this is a swirl sign. It means that that blood is still liquid over there. So the bleeding is still ongoing. So it might, at this moment, the thickness may be 14. Maybe the patient is doing well, but after some time, maybe half an hour, but sometime later, with more bleeding, there will be more compression, and the patient would clinically deteriorate. So while assessing severity, one must look whether the extradural hemorrhage is black, whether any part is heterogeneous or having black content. That means the bleeding is still ongoing, and clinically the patient needs to be monitored more. The other thing, this is our own case. So the patient was not doing well. The patient had a trauma, and after that the patient, a child, was very drowsy. And in CT scan, I said, the CT scan is absolutely normal. And subsequently, the patient did not have any other injury, like maybe the patient did not have any abdominal bleed. So there was no other reason for the patient to be drowsy after the trauma. And in this case, we did an MRI, because there is a type of injury called DAI, diffuse axonal injury, which is not detectable in CT scan and which only gets detected in MRI. So if a patient is not doing clinically well and the CT scan is normal, we have to order an MRI, and look how subtle these findings are. These are diffusion restricted images, and they look some white dots over here and white dots over here. So that was the reason why the patient was drowsy. Next, I move to the other aspect, is that once we detect an injury, we should also be able to detect whether this injury is fresh or that injury is old. This is another case from our hospital. This was a 4-year-old, this was a 1-year-old child who his older brother, 4-year-old brother, had inserted a knife, kind of blade or knife, sharp object, through his skull. This is the entry point through the skull bone, and caused a bleeding, internal the brain hemorrhage over here. And this happened on 26th of January this year. And 3 months later, we have a follow-up of this follow-up image where you see that this part of brain where previously there was hemorrhage has now become black. Initial change was white because it was hemorrhage. Now this area has become black or hypotensive. The reason is this area has become now encephalomyelitic or gliotic. So an old hemorrhage, an old trauma on CT scan look black. This we need to know because there is another case where there is an old hemorrhage. There is an underlying the injury. There is some hypotensive areas, but at the same time we see that the skull bones have by then, this is 3 or 4 month old injury. Skull bones by then should have closed, but they have not fused, and there is some swelling outside. So this would be a growing skull fracture. So these are the two things that we need to know, that we should be able to differentiate on imaging whether this is an old injury or a recent fresh injury. And these are some common appearance of neurosurgery, post neurosurgery procedures. Like this is bar hole. So often these hemorrhages are taken out through bar holes, small holes in the skull bone, or sometimes for larger hemorrhages, sometimes our neurosurgeon does this they do a craniotomy. That means they remove the skull bone temporarily and then put it back. Often our neurosurgeon does a partial craniectomy. That means they remove the part of skull bone and later they fix it through cranioplasty. Another option is by often intraventricular hemorrhages. An intraventricular drain is put through a hole like this. So in our hospital, we get to see all these neurosurgeries, and so post neurosurgical procedure, we need to identify these changes. So that brings me to the end of this topic, CT in head trauma. The summary would be that it is the most common CT indication in our practice. In the report, we describe the intracranial hemorrhages, skull bone fractures, and extracranial soft tissue injuries. In report, we also describe what are the indicators of severity. And if we get a swell sign in the image, it means active bleeding is still happening, and we need to monitor the patient very aggressively. If a patient is not doing clinically good and CT report only says that there is minor injury that cannot explain the clinical status of the patient, then please send the patient back for MRI to rule out diffuse axonal injury. And so there are some common neurosurgical procedures that we saw in CT scan. So this slide I added. It is kind of, I have given the heading expectations of the radiologist. So once we get a patient for CT scan, we expect some basic clinical information that would really help us to interpret the images. That information is what is the mental status or orientation of the patient after trauma. Because if we see that we are finding nothing in the CT scan, and if you have written that the patient is not doing clinically well without any other injury, then we ourselves would advise the patient for MRI scan. So this information is very beneficial for us. Secondly, we'd like to know if there was any nosebleed or ear bleed, because this means there could be skull-based fractures, and skull-based fractures are very difficult to diagnose on ordinary CTs, and often we need to do HRCTs for those purposes. So this information is very critical for us. We'd like to know after the trauma if the patient had any vomiting, periodic loss of consciousness or seizure, and if there is any contraindication to sedation, because often these children are often keep moving and subtle fractures, subtle hemorrhages are not detected if the child moves. So, but then giving sedation to a head injury patient can be very tricky. So, help whether this patient can be given sedation it would be very much appreciated from the radiologists. Next, we move on to COVID pneumonia topic. Now, we have scanned more than 3,000 CT scans for COVID-19 pneumonia in last 1 year. But to be honest, we have scanned very little pediatric cases. The reason is most of the pediatric cases were managed clinically with X-rays. So most of the images that we will be showing for COVID-19 pneumonia, I will be covering almost the entire spectrum, would be from middle-aged patients or young adolescent patients, but not hardcore pediatric patients. And we will be covering an entire spectrum. Again, for COVID-19 infection, whenever we report a case, we usually tell certain facts, like what is the major type of lung lesions that we are seeing in the scan. Second, through our report, we communicate that how confident we feel that this is COVID-19 infection and not something else. We also communicate how severely the case is, the patient's lungs are affected by COVID-19 infection. And the fourth thing that we communicate to the clinicians is whether there is any other potential problem that the clinician needs to know apart from COVID-19 infection. So when we make films, we give two types of images in CT scan. One is the lung window images and other is mediastinal window images. The lung window images are white like this. Here we see the lung in great details. And then the mediastinal window images, this is the black image. Here we almost see nothing of the lung. The lung is entirely blacked out. And we see about the mediastinum, heart, and the chest wall, and this. So for COVID-19 infection, we need to focus on the lung window images only. Then lung window images can be axial images as well as coronal images. Axial images mean the images have been acquired in the axial plane. And coronal images means this is the coronal plane. So this is a coronal image. That means the image is being shown in the coronal plane. We have to see lung window images, axial and coronal images for COVID-19 infection. Now I'll go through some of the common lesions that we see in COVID-19. So ground glass opacities often we find in the reports. Ground glass opacity means that these are the ground glass opacities, the faint white patches, and this is a normal lung. In almost the remainder of the talk, whenever I show a pathology, I have tried my best to place a normal image side by side so that we can compare and readily detect the abnormality. Here, this is the pathological side. This is a ground glass opacity. These are normal vessels. This is a normal lung, and these are normal vessels. These are vascular markings. If the opacity is fainter than the vascular markings, we say that this is a ground glass opacity. That is the definition. Because we can see the vascular marking through this opacity. So if a white patch is fainter than the vascular markings, then we say this is a ground glass opacity. On the other hand, this is an example of a consolidation. This is also white. This is also located within the lung, but they have the density exactly to the vascular markings. This is a consolidation. And the consolidation is as much white as the vascular markings. And the third type of lesion that we see is crazy paving pattern. That is just like ground glass opacities, but inside there will be fine reticulations. I am not sure if through the Zoom portal we are able to see the reticulations, but here there is ground glass opacity, and inside the opacity there are some irregular fine markings which we can see. So there are three types of lesions: ground glass opacity, where the lesion is faint white and definitely less dense than the blood vessels. Then there is consolidation, which is white, as much white as the blood vessels. And there is crazy paving, which is ground glass opacity, but then there are small linear markings within it. These are the three lesions that we see in COVID. Along with that, we see a very peculiar parenchymal band or reticular pattern. So this is a very irregularity rope-like white lesions. This is the normal lung at the corresponding position. These white irregular parenchymal bands are very typical of COVID. We describe it like this: parenchymal patterns or reticular pattern. And some subtle sign is the vascular engorgement sign. It means that usually the blood vessels are very narrow caliber in the periphery. But in COVID patients, the vessels that are reaching up to the periphery can become dilated. This is the normal size. Even this is the normal size of blood vessels, very narrow caliber in the periphery. They are wide caliber towards the center, towards the heart. And in the periphery, they should be very narrow. But here we see the blood vessels are becoming dilated. So this is vascular engorgement. So these are the 5 signs. So for COVID-19 infection, I have described what are the common 5 lesions that we see in COVID-19 infection. Now I would like to say how we describe that, how we communicated to the clinicians that how confident we feel that these lung lesions are due to COVID-19 infection, not due to any bacterial pneumonia or due to any tuberculosis. This we express through this CORADS. We give a CORADS score. CORADS full form is COVID-19 Reporting and Data System. This peculiar name arises from other similar reporting and data systems that are present in radiology, involving breast cancer, thyroid, and so this has been copied from there. So it is CORADS means by giving a CORADS score, we wish to communicate to the clinicians how confident we are that these are COVID-19 infection. This has nothing to do with the severity of the lung affected. So if we see ground glass opacities that are present more towards the periphery of lung, so by periphery, we mean that it is not central. Central lung is lung that is in touch with the heart. So here we see that the majority of opacities are in the periphery. This is very typical for COVID-19 infections. And the other factor is, if more of these lesions are in the lower lung, more than the upper lung. For example, in tuberculosis, we see more lesions in the upper lung. But in COVID-19, we see lesions in the lower lung. So if we see these 2 factors, we say this is CORADS 5. So that means we are kind of quite sure that this would be COVID-19 infection. So CORADS is like this. If we say this is CORADS 5, it means we have imaging wise a strongest suspicion that this is COVID. If we say CORADS 3, it means that this is non-specific. This may be COVID, may not be COVID, we don't know, do RT-PCR. And if it is CORADS 1, we say this means we are trying to tell that this is not COVID. So, and CORADS 4 and CORADS 2 are kind of in between. So while these lesions with peripheral dominance and lower dominance would get a CORADS 5 score, similarly, if we get a normal lung and some other lesions, here we see bronchiectasis, large nodules and masses, but this would not be COVID-19, and so this would get a low score, CORADS 1, like that. And CORADS 6, this has nothing to do with radiology. CORADS 6 means the patient is RT-PCR positive. We only say this is CORADS 6 once we know that the patient is recently RT-PCR positive. So now that I have described what are the lesions found in COVID-19 pneumonia and how we express our confidence in describing saying that these are COVID-19 pneumonia. Now I'd like to say how we express that how severely these lungs are affected. So we give this through another scoring called CT severity score. So a lung has 5 lobes, 3 in right side, 2 in left side. And for each lobe, we give a maximum point of 5. If the particular lobe is involved more than 75%, we give a 5. If it is involved 51 to 75%, we say 4. So for each lobe, we are actually grading the severity. So 5 points maximum for 5 lobes, the total point is 25. And then we say what is the score of this patient? How do we calculate? Our modern scanners, we are lucky to have a 128 size CT scanner, and in our scanners with these recent technologies, the machine itself calculates, finds out how many, like what is the each lobe volume, and see these are images the machine itself has generated, and each lung lobe has been given a different color by the machine, and then the machine itself detects that these are the consolidations of COVID-19 infection. So the machine itself detects by a technology called segmentation analysis that how much part of lung is normal looking black, how much is white, and it gives a score like this. The machine generates the score. So for example, here the CT severity score is 11/25. So we kind of give this score, and also as our machine is calculating the exact percentage, we also say that the lung is, we give a approximate 20 to 25% of the total lung that is affected. This scoring is universally accepted. This new technology may not be available everywhere, so it is still not accepted. But in our hospital, we always give a single value, like 20 to 25% percentage is affected, and we get it directly from the machine, and is often very accurate. In CT scanners, older CT scanners where this software is not available, there what we do is we see the fissures, and then we manually identify lobes. The lobes are differentiated on the basis of the fissures, and then we calculate, do a mental calculation how much each lobe is affected, and we give an approximate score. Since we are telling a lot about the CT severity score, at this moment I feel it is we should be discussing that whether this CT severity score correlates with the clinical situation of the patient. We have done a lot of COVID-19 scans, and we have seen that CT severity score usually parallels the clinical symptoms of the patient, but there are some notable exceptions that we need to remember. One is that if a CT is done very early, say 1 or 2 days of fever, then the lung might not have been affected by them. So then the CT score would be low, but subsequently the patient would become symptomatic and go on to have hypoxia. So very early CT scans usually don't do good in predicting the course of the patient. Again, very late CT scans also don't do good, because once this COVID-19 infection lesions happen, they stay in the lung for maybe 1 month, 2 months, but clinically the patient often improves after 15-20 days. So there is a clinical and radiological mismatch if we scan the patient after say 20 days. And lastly, the CT scan may say the lungs are only minimally affected, but it also depends on the cardiac status of the patient. Suppose the patient has a congenital heart disease. So even with minimal affection of the lung, the patient may go to dyspnea, have dyspnea. So while taking consideration the CT severity score, these are the things that often help us. So common lesions in COVID-19, how confident we are that these are COVID-19 infections through SPORAD score, how severe the lung is affected through CT severity score, and in our case also the direct percentage. And lastly, we often communicate through the images. If the clinician needs to know about any other potential problem that may happen or that has happened, so we'll show some examples from our hospital. So this was the patient CT scan on admission, and after a few days the patient started having breathlessness, and we see the patient has developed a pneumothorax. The pneumothorax is very common in COVID-19 patients. This is pneumothorax, air outside the lung and inside the ribs. This is pneumothorax. Similarly, this is another patient. This image is during admission, and this image is after some time, where we see air in the mediastinum. So this is air. Black thing is air. This was not present in this image. So this is air in the mediastinum, This is called pneumomediastinum. Pneumomediastinum has two problems. Once this air will start pushing the heart, and also this air may come out and into the chest valve, and then the patient's body will swell and he will have difficulty in breathing. This is another case. This was the CT in admission, and after a few days, this happened. So we see a new onset cavity. This cavity was absent at the time of admission. So this was proved later by galactomannan assay. We do a galactomannan assay and a sputum for KOH in these patients, and in this assay, this came to be positive. So we thought this would be invasive aspergillosis, and we treated with voriconazole. And the patient has been doing good. So that comes to the conclusion of COVID-19 infection. Again, we have some expectations that I'd like to share on. So any information if you give about the RT-PCR status, that is very helpful to the radiologists, because if it is RT-PCR positive, then codads become meaningless for us. We only need to say how severe the lung is affected, or if it is affected at all. We need to know how many days since after the onset of symptoms we are scanned, because then we would be able to suggest ourselves. If the scan is within 1 or 2 days of onset of symptoms, we might write in our reports that please monitor the patient clinically, because the CT scan has been acquired early. And we would also like to know if some previous X-ray or CT available for comparison, because if we see a cavity in a patient of COVID-19 infection, we need to know whether the cavity was there from the beginning or it is a new onset, because new onset cavities are rarely because of TB and mostly because of fungal infections and other bacterial infections. And this fact that how well the patient is doing clinically also sometimes helps, because often these patients are dyspneic and we get false ground glass opacities because of respiratory distress. So higher is the slice of the CT scan, the better the machine is able to image these dyspneic patients who have a high respiratory rate. But still, if the patient is doing very good, if the patient is not having any dyspnea, then if we get a ground glass opacities, we look at the trachea and understand that, oh, this must be because of expiratory imaging, and it is artifactual. So some knowledge about what is the SpO2, current SpO2 of the patient really help us. Subsequently, I would cover some small topics scattered, and I start with suspected foreign body in child. This is another common indication that we get. Most of the times, the X-ray may be able to solve. For example, here, if you see a round object which is circular in epithelium and then slit-like in lateral images, we know this is in esophagus. But again, images may be like this, X-rays. So we see that the left lung is a little darker than the right lung. And this may often be artifactual because of rotation of the film. One trick is to have an expiratory film, ask the patient to get imaged in expiration. And then if we still see that, we'll see that if there's an obstruction to the bronchus, that difference will get very exaggerated. This is a very nice, neat trick to image. Despite the chest X-ray imaging, it might happen that still there is a clinical suspicion of foreign body, and we need to image through CT scans. Our modern day CT scanners are able to image in any plane, and this is a case from our own Kuchbihar, from one of my friends, and we see that in the bronchus there is a vessel that has got impacted. We are able to see images like this. So these are two cases. This is the vessel. So we see so clearly if there's a foreign body within the bronchus, we are able to see, and this is a suspected as foreign body aspiration. Foreign body that we did, and this is the normal appearance. This is an image that we acquired today, and we see that how well This is the trachea. And then this is the right bronchus, left bronchus. Right bronchus divides into two lobar bronchi, and the left bronchus divides into three. And left bronchus divides into two branches. The right is three. This is one. This is two. This is three. So we are very in CT scan. We are very clearly we are able to see any foreign body that is present within the larger airway. And here I would like to show a small 1 minute video of some virtual bronchoscopy that we are able to do in our scanners. This was the foreign body patient that had a foreign body impacted in the right bronchus. Here we see we are going from superiorly. This is a virtual image. We are going superiorly from the mouth, from the top and towards the hilum. We are within the trachea. These are the tracheal rings. And now we have reached a place where this is the hilum. This is the hilum. Here in this direction would be the left bronchus, and in this direction would be the right bronchus. And this is the foreign body that is impacted. So we are able to see what the bronchoscopist would be able to see. This is the hilum. This is the left bronchus. We can navigate into the left bronchus. This is normal appearance. This is normal appearance of left bronchus. And this is the hilum. And as I go back, I can see this is the foreign body that is impacted. And subsequently, we were able to retrieve the foreign body, and this was a whistle. And this is our baby. Similarly, there was another case which was suspected to be because the symptoms started very rapidly. We are not sure where the patient had eaten something. And this was the X-ray. The patient's SpO2 was low on the lower side. So there are some suspicious consolidations, but very difficult to confidently say. Clinically, there were crepitations and bronchi over the right lung. And we did a chest CT. And in this CT, we are seeing that there are some faint ground glass opacities, and they are mainly around the bronchus. And here at the lower level, we are able to see consolidation. This is consolidation. But this consolidation is different from the consolidation we saw in COVID, because COVID, it was lying periphery. And here it is around the bronchus, that is central. And from this distribution, that is consolidation and ground glass opacity in the lower lobes, and from the rapid onset with everything had started, this was aspiration pneumonia. And the patient got treated conservatively and then improved symptomatically and was discharged after a few days. And this was the X-ray. This was the X-ray during discharge. And so during discharge, the patient had very less symptoms. So it's very and this was the X-ray during admission. So it was very difficult to diagnose on X-rays. But on CTs, the images were very evident. And now once we see the CT, we realize that there were some faint consolidations once we compare this region and this region during discharge. But this would be very subtle in X-rays. So we have covered almost the four topics, like head and chest, basic anatomy, trauma head, COVID-19 infection, foreign body. That is like 80% of what I intend to say. Now I will be discussing some clinical indications and some images that we get to see in CT. But in all these clinical indications, MRI would be the best imaging modality. But still, we do CT sometimes, and so I'd be describing them. So this would be, so if a patient is suspected of meningitis, clinically if a patient is suspected that he is having meningitis, contrast-sinus MRI is the investigation of choice. But it may happen that MRI is not available, or it may be quite costly. So often we get to see a CT scan, plain CT scan. And in plain CT scan, the only finding that we might pick up is dilatation of the ventricles. So this is lateral ventricle. This is also part of lateral ventricle, and this is third ventricle. And here I am showing a normal image. So normal appearance, the lateral ventricles are like this, narrow, slit-like. And here we see that there is a dilatation. And around the dilatation, we see a faint, ill-defined hypodensities. So comparing with the normal side, this is a hydrocephalus. So this might be the only finding in plain CT that we get in a case of meningitis patient. Now, if we do contrast CT, so this was again a patient of meningitis. Plain CT was near normal. There was some prominence of the ventricles, but not that prominent like the last case. But once we do contrast, we are able to see that the sulcal spaces, they are showing enhancement. When compared to the plain study, we see that the white lines have increased in the sulcal spaces. You see here, here, and here. So this is kind of sulcal exudate that we get to see in meningitis. And this is another case of meningitis of a basal exudate. And the normal appearance is like this. We see black basal cistern over here. But here we are seeing that that the cistern is enhancing with contrast. So this is basal exudate. So basal exudates favor diagnosis of TB more than sulcal exudates. But again, CSF study would be needed for confirmation. To summarize, in a suspected case of meningitis, please order CMRI, contrast venous MRI, if it is possible. If it is not possible, CT scan would be better than NCCT. Please mention it is a suspected case of meningitis in indication itself, because then we would be doing a delayed scan in CT. It does not cost anything extra, but we will be taking another image which helps in detection of this sulcal exudates. So we don't take the delayed scan routinely in all cases. So if we know prior that this is suspected meningitis, we'll be taking a delayed scan. And basal exudate and parenchymal lesions favor a diagnosis of TB over pyogenic infection. Next, we come to another topic of seizures. Again, for seizures, the investigation of choice, if the patient can afford, is a MRI scan. We have a separate protocol for MRI scan brain for seizure. We call it seizure protocol. So there are many pathologies that won't be detected in CT and would only get picked up during an MRI scan. But still, because of financial issues and availability, it often happens that for seizure patients, we do a CT scan first. And there are some findings which can be detected in CT scan. I will be showing them. So these hyperdense white colored spots, if we see them, we describe it as calcified granuloma. These hyperdense spots may be responsible for the symptoms, may not be responsible if it is only hyperdense foci, calcific foci that we see. But along with this calcified granuloma, if we see that there are some hypodense areas adjoining, then these are calcified granuloma and edema. That means these are definitely pathogenic and they are in an active stage and needs treatment. So while interpreting the report, we have to tell whether this is only calcified granuloma or whether this is calcified granuloma and edema, because then the implications are different. And similarly, sometimes we may only detect the edema and we may not be able to see the calcified granulomas. So then the findings, definitely this is pathological, and the findings, and this is kind of non-specific because many diseases can lead to this white matter edema, and we have to do a CT scan. And if we do a CT scan, often we find this sort of appearance, ring enhancing lesions. But we would not be able to tell from this CT scan with ring enhancing lesions that whether this is due to NCC or this is due to tuberculosis, for which we have to do an MRI scan with MRI spectroscopy if possible. Because MRI scan, if we are able to see the scolex, then we are able to confidently say that this is due to NCC. And despite MRI scans, often it's a very difficult clinical and radiological problem, whether this is NCC or this is TB. Other condition where it helps is in case of hypoxia ischemic encephalopathy. Again, subtle hypoxic ischemic encephalopathy, early hypoxic ischemic encephalopathy, or mild involvement will not be picked up by a CT scan and will be picked up only by MRIs. But here we see a very severe hypoxic ischemic encephalopathy that in an late stage. So normal at this level, the normal ventricles look like this. The normal ventricles look like this, thin slit-like. Here we see a dilatation. And then the normal brain parenchyma should be like this, gray. But here we see black, 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 black. So all these are cystic encephalomalacias that has developed in HIE. But this is a very florid advanced case. We won't be able to detect HIE in CT in most of the times. The other situation where CT is very helpful, and in a case of a patient of seizures, is if we see some heterogeneity, some black-white areas in the posterior fossa, heterogeneous attenuation in posterior fossa. And it is usually due to tumors. 3 tumors are common in the pediatric population in this location that we won't be able to differentiate in NCT. We need a contrast CT, and contrast MRI would be the best investigation. I would say why. But before showing the images, I would like to share with you one line about each tumor, that one characteristic line. For pilocytic astrocytoma, the appearance in CT most of the time, not every time, most of the time, is a solid enhancing nodule within a cystic region. For ependymoma, the characteristic thing is a tumor that is arising from the floor of the fourth ventricle. And for medulloblastoma, it's a tumor that is arising from the roof of the fourth ventricle. And on imaging, CT imaging, they look like this. Pilocytic astrocytoma still can be understood. Like this is the enhancing nodule, this is the cyst. But on CT, ependymoma and medulloblastoma is practically very difficult to be differentiated. And in both these cases, contrast MRI of the whole brain and spine is some basic requirement. This is because these tumors spread through CSF, and the neurosurgeon, as soon as we refer this case to neurosurgeons for definitive treatment, they would require a contrast enhanced brain and spine study, contrast enhanced brain and spine study through MRI. So difficult to differentiate ependymoma and medulloblastoma in CT. We need contrast enhanced MRI scans of the whole spine and brain before surgery, because we need to know whether there is meningeal metastasis. But still, CT scans can help, because we can look whether there is pressure on brainstem, whether there is herniation of brain, whether there is obstructive hydrocephalus that is developing. So kind of the severity of the situation we can assess through CT report, but these tumors require MRI study. So to conclude this part, whether a patient with seizure disorder, MRI brain epilepsy protocol is the investigation of choice. A number of pathologies like gray matter heterotopia, mesial temporal sclerosis, focal cortical dysplasia, which cause pediatric seizures, won't be detected in CT scan. CT scan would be absolutely normal in these cases. May be normal in these cases. And in CT scans, if we get a CT scan done, we usually look at whether there is a calcific foci, whether there is hydrocephalus, whether there is any abnormal atrophy pattern as in HIE, or whether there is any SOL that we in posterior fossa. Lastly, I come to the final topic of radiation dose in child. No discussion in radiology on pediatric CT can be complete without and preliminary discussion on the radiation effects of CT scan. So what is the problem of radiation dose? The main concern is cancer. a child may develop cancer if a child gets a CT scan. But the cancer is likely to develop 20, 30, 40 years later down the line. And this is a stochastic effect. That means the severity of cancer has no relation to the number of CT scans. Only the probability has. If there are more CT scans, then the child might develop a cancer. The probability estimation we have tried, like a lot of scientists have tried over the years, it is something like 1 in 10,000, and it varies from cancer to cancer, at which age the child got exposed. There are many factors, so it is difficult to estimate. And the cancer will happen maybe 30, 40 years. So if we irradiate child, there will be a very like 1 in 10,000 or 1 in 8,000 probability that the child will have cancer after 30, 40 years. But this problem is more for pediatric population than for the adults. The reason is that children have a higher fraction of growing cells, and they are likely to live longer. So for all practical purposes, if a CT scan gets done on a 60-year-old, he doesn't need to worry, because if he gets a cancer developed after 20, 30 years, then that will have a less impact. CT scan will be more life-saving. But for pediatric population who have a significant life expectancy, this is important. The risks are within that. So how do the CT scan machine tackles this problem? And how do we measure it? So recently, there are a lot of controversy has been created by the AIMS director, Dr. Guleria's comment that CT scan leads to cancer. And then there were kind of ABP Ananda's news articles, and they had programs over there whether CT scan actually leads to cancer. So we need to be able to measure that how much exposure the CT scan study has done. We do it through a value called DLP. After every CT scan, the machine, all modern machines give a value called DLP, dose length product. Then we put it in a formula, and we get an amount of effective dose, and we express it in millisieverts. For a chest X-ray, that effective dose is 0.1 millisieverts. And if we live 10 days in this earth, we would be getting the same amount of exposure, background radiation exposure. So 10 days of life is equal to 1 chest X-ray, and that is 0.1 millisieverts. And the modern CT scanners have quite an elaborate mechanism to decrease the amount of dosage. So we are able to scan at 70 kilovolt. So that means there is a reduction of dosage up to 50% when compared with 80 kilovolt. 80 kilovolt scanners are where the industry standard 5 years ago, 80 kilovolt CT scanners. Now, newer CT scanners can scan at 70 kilovolt. They are dedicated, they're targeting the pediatric population, and that costs 30-40 lakhs, probably more than the 80 kilovolt scanners. We have this 70 kilovolt scanner, and at this very low tube voltage, there's 50% reduction in dose. The other thing is the iterative dose reconstruction technology. They also reduce the dose to more than 80%. So one chest CT in a pediatric population, in our 120 slice CT scanner at this 70 kilovolt, we measured it, and that effective dose is 0.5 millisieverts. That is effective, that is equivalent to 5 chest X-rays. So back in 5 years ago, it would have been equivalent to 100 chest X-rays, 200 chest X-rays. But now with this costly technology, but still very effective technology, the CT scan effective radiation dose for 1 chest CT might be as low as 5 chest X-rays. And this is an example of what the software does. With the new softwares, with low dose, images are as blurry as this, but then through reconstruction, we get very clear images. So even with low dose, we are able to see better. So this is an example of how the modern CT scanners take solve the problem of radiation. But nonetheless, radiation is an important factor. pediatricians need to know about it, and we radiologists need to make sure that we have the best machines and we are dedicated enough to reduce the radiation dose as much as possible for our children. So that brings to the end of the formal talk, and I am happy to take questions.
Thank you, Dr. Shobrat. That was a very excellent, lucid deliberation. You have actually uh, made it so very easy for us that from henceforth we'll be able to pick up the basics of the CT scan of our patients. And one thing, request to all the colleagues that what Dr. Shomrat said, that we got to furnish a few of the history as well as some symptoms and signs to the radiologist as well as to the pathologist for any histopathological examination also, so that it becomes easier for them to pick up things, to report more lucidly. So that should be borne in mind by my fellow pediatricians. And as far as the questions are concerned, is there any questions in the chat box? Hello, Shinajit.
There are 2 questions.
Where is it? Nishant, I'm not getting it. The questions.
One person from Howrah.
Vinod, you can proceed. Yeah.
No, I can see it just popped up. One question popped up from a colleague from Howrah, but
Yeah.
I'm not finding it.
Nishant, nothing we are getting in the chat box.
Yes. Dr. Prosenjit Ghosh Howrah. He said, please elaborate HRCT classification in case of COVID-19 as well as pneumonia of other causes.
Okay.
Samrat.
Yes. HRCT classification of COVID-19 pneumonia. So, with COVID-19, we give 2 scores. 2 scores. One is CORADS and other is CT severity score. With CORADS score, we like to tell how confident we are that these are COVID-19 infections, and so that I understand that the question means that how do we differentiate COVID-19 from other infections? Is that so? If it is so, if the lesions are in peripheral location and in lower lobes, then they are likely due to COVID-19 infection. But if there are cavities or nodules or cysts or pleural effusions or lymph nodes, then they are unlikely to be due to COVID-19 infection. And COVID-19 infection is very difficult to be differentiated from other viral infections like influenza. And if after repeated RT-PCRs and RT-PCRs for COVID-19 as well as for viral infections, then other rare causes like organizing pneumonia and drug-induced changes, they also come into factor. But in this pandemic, usually if we see a pattern like of CORAD spike, we initially think about COVID-19 infection.
Yeah, the next is a question from Dr. Oshumanju Hajira from Ranaghat. He wants to know about the CT findings of the torch infection. Okay.
So for torch infection, congenital torch infections, here for CMV, like CMV, there is like calcifications in brain periventricular region, and there can be abnormal atrophy patterns also. So these are usually detected even in ultrasound antenatally, and in postnatal neonatal period we detect them, but then we are also aided by other pathological tests.
Yeah, there is another question from Kolhapur, Maharashtra, Dr. Sai Prasad, and he wants to know what is the epilepsy protocol as far as the radiological part is concerned.
Right. So in addition to the normal brain MRI, we acquire few other scans. we would like to see the gray matter and white matter differentiation very well. For this, we do a 3D T1 sequence, and we also have some inversion recovery sequences that we apply to see the gray-white matter junction. So this is done to evaluate heterotopias. And we also like to see the hippocampus very well. So we have these 3D T1 sequences measuring the volume of hippocampus, and they are acquired in a special coronal oblique manner.
There is a question from our own Dr. K.S. Rana from Kuch Bihar. When should we go for a CCT and when to go for an HSCT in children? Please mention the indications.
For most of the diseases, we get to know through HRCT. CCT is an HRCT scan plus a contrast scan. This contrast helps to evaluate certain aspects like lymph nodes. If we give contrast to a lymph node, and if the central part of lymph node is not enhancing, then it's a necrotic lymph node, and that would favor a diagnosis of tuberculosis. Similarly, if we give contrast, we can look at the bronchial arteries, pulmonary arteries, and often chronic tuberculosis patients have hemoptysis because of aneurysms that develop over there. So for detecting pneumonia, HSCT is okay. But if we find in HSCT that there are lymph nodes, enlarged lymph nodes, or we are suspecting TB, we need to know whether it's active TB or this an old TB. Then contrast enhanced scans would be good. In our hospital, for indoor cases, the radiologist gets to decide where to do the contrast scan, where to do the HRCT scan. They just send the protocol is to send chest CT, and we take care of everything, and we decide that.
From Dr. Chandrakanta Ghosh from Kolkata. He says that he has seen some patients who are PCR negative done twice, but their CT chest is actually indicative, diagnostic.
Yeah.
So he wants to ask whether it is possible. Yes, sir, it is possible. And he says that treatment should be given in the line of COVID management. Yes, the protocol says so. So there is any other questions?
Dr. Ashumanja Hajra Ranaghat said wonderful CAB, and he conveyed his thanks to us. Thank you, Dr. Hajra. How much is the dose of radiation?
How much is the dose of radiation in MDCT chest?
Yes, in MDCT chest, in our 128 slide scanner with 70 millivolt protocol and iDose 4, the radiation is 0.5 millisieverts, and that is equivalent to 5 chest X-rays for single scan. And if I repeat the scan with contrast, it will be equivalent to 10 chest X-rays.
With this,
so I think there is no questions as such anymore. We come to the end of this session. It was absolutely a fabulous session, and so good was the class taken by Dr. Shamrat that we all basically learned many things. And thank you, Dr. Shamrat. And I would also like to take the opportunity to congratulate as well as thank our members of the Kuch Bihar Doors Academy. So they were so much enthusiastic that I and the president, Dr. Binayak Rai, was actually, we took this chance of organizing this Saturday classroom webinars, which will go on. And once again, thanks to Dr. Shamrat for his very excellent deliberation, and also to Sun Pharma for actually letting their digital platforms for us. Thanks, Shenajit and Mr. Nishant. I want to conclude the thing with a few words from Dr. Binayak Rai.
Last but not the least, thanks to Dr. Shamrat. The total session was so attractive that I suppose no one could leave the seat and go to toilet. It was so that otherwise we could miss some points. And all these things, 90% of the topic and the presentation are totally new to us. We get enlightened, and Dr. Shamrat will not leave you in future. We'll call you, of course. And thank you very much to all, and God bless you all. Thank you. Good night.
Thank you. Thank you. Good night, everybody.
Thank you, sir. So can I end the meeting with your permission, sir?
Yeah, yeah.
Thank you. Thank you. We can end it.
Okay, so I'm ending this meeting now. Thank you.
Thank you.